It's my pleasure to introduce Professor Karen Smith for this first session. Karen is the Research and Evaluation Leader for Ambulance Victoria. She's an adjunct professor at the Department of Community and Emergency Health and Paramedic Practice and the Department of Epidemiology and Preventive Medicine at Monash University. It's a great CV, thank you. Professor Smith chairs the Victorian Ambulance Cardiac Arrest Register, and we had the pleasure of sharing your input on the inaugural academy for the last couple of days as well, Karen, so that's been great fun. And today your session is going to be the implementation of collaborative response models for elderly fall patients. Ladies and gentlemen, Professor Karen Smith.
Thanks everyone for coming to this session, and it's my great pleasure to present this project, which is a collaboration with the Alfred Hospital in Melbourne, Victoria, and it was funded through Better Care Victoria, which is a sort of innovation, a new kind of line of funding available to health services in Victoria for sort of innovative projects. I presume I just click the arrow? Yeah. So just a bit of background around elderly falls and what the research tells us. We know that approximately 40% of people over 65 in the community will fall every year, and we have an increasing number of falls resulting in calls to ambulances, partly because of an ageing population, but other reasons in terms of comorbidities and their association with falls. And falls can have a cascading effect on older adults, including decreased confidence, reduced activity, functional decline and a reduced quality of life. And not surprising that the highest predictor of having a fall is having had a previous fall. And research has shown that older non-transported falls are at increased risk of recurrent falls and ambulance reattendance. And almost half of those not transported to hospital will have an unplanned care contact within 28 days. However, routine transport to an ED as the default disposition following a fall is questionable when there's it may not be effective or efficient use of resources or the best care for the patient in the absence of physical injury or change in functional status. So in our area, we saw there was a need for a service in the collaboration with the Alfred Hospital. So for looking at our data, falls for the 65 years and over account for about 16% of the Ambulance Victoria calls within the Alfred local government areas. And the Alfred, looking at their data, saw over 600 admissions to the ED for elderly falls in a year. And 13% of patients admitted to the ED secondary to a fall were readmitted within 28 days, and 46% of those required an inpatient stay. Also looking at our data, we saw that the vast majority, not surprisingly, were falling during the day when they're up and mobile, and 31% of them didn't have any active treatment from paramedics at the scene, and we didn't transport around 27, almost 30% of them as well. So that led to the reason for the service and our funding application to Better Care Victoria. We saw an opportunity to prevent hospital transfers or from paramedics to the hospital of fallers, and also ambulance reattendance, an opportunity to prevent future falls and increase confidence and quality of life. And no rapid alternative allied health model currently existed in the Alfred catchment area, or in fact in metropolitan Victoria or in Victoria at all. So that led to the development of STRIDE. The Alfred came up with that sort of great name, so a service to reduce risk, improve independence and decrease emergency admissions. Like I said, it's a collaboration between Alfred, AV and Better Care Victoria. It's delivered within the patient's home environment by a sole practitioner who's a first responder, physiotherapist or occupational therapist. And they have the clinicians at grade 3 allied health practitioners. We wanted experienced practitioners, so the Alfred set the criteria for at least 7 years experience, targeting patients aged over 65 who've had a fall from a standing height and can be tended at the home and don't need emergency transmission. So it follows triage by either the ambulance paramedics seeing the patients or through our referral service which I'll go through in a little bit more detail. So the team's available Monday through to Sunday and operating 12 hours, 0700 to 1900, with the last home visit referral able to be made by 5 o'clock in the afternoon. But they are allowing next day referrals for patients that can be safely left at home that we wouldn't normally transport anyway. But the idea is during the day that the falls clinician gets to the patient within 2 hours of the referral. So it is a relatively rapid response. So the objectives are really just to determine the feasibility of this as a service that paramedics can refer to, and that we can also refer to through our secondary triage service. Establish if there's a demand. Establish the impact on falls-related healthcare utilisation of ambulance and the EDs. Identify the knowledge and skill set required by the STRIDE clinicians, and we're going to be measuring client satisfaction and perceptions of the service and staff satisfaction and perception of the service. And the main primary aims are to reduce unnecessary emergency transports, reduce the number of presentations to the ED as a result of falls, but from a more patient benefit level to improve the overall effectiveness of falls management and prevent future falls for patients aged 65 and over who are falling at the home. This is a very busy slide, but really just shows our triage mechanism. So when Ambulance Victoria runs a secondary triage service, so when calls come through to 000 and a triage through primary triage of AMPDS, certain codes that we have deemed to be safe for secondary triage go through and are triaged by paramedics or nurses, and they can be triaged away from an emergency ambulance response. So the falls service have been added as an alternative service in our secondary triage referral service facility, but the other main way that the referrals will be happening are when a paramedic attends a patient, decides that they can be safely left at the home, then they consent the patient to giving their details to the STRIDE practitioner, who then makes an appointment to see the patient within 2 hours. Now, this is also quite a busy slide, but it's just really showing once the triage, the STRIDE practitioner gets to the patient, the first thing they do is a post-fall screen. So they're really just looking in the first instance, they've got a standardised screen they need to do to see if they actually need to escalate back to get the patient to the ED, or whether they need to call the ambulance. So it's a primary survey, neurospinal assessment, mobility assessment, vital sign assessment. If the patient is deemed safe to be then further assessed by the clinician, they do a comprehensive assessment where they do a previous fall history and risk assessment. They do a functional assessment around activities of daily living, looking at quality of life through the EQ5D, which is a common quality of life assessment tool and has available population norms. They complete a falls self-efficacy scale and a fear of falling. They do a balance screen. They do a whole complete home environment screen. They do a visual testing if deemed necessary, a dizziness screen, again if deemed necessary, and they're also now taking dipsticks and doing urine testing if they think that may be relevant and required. And then based on what their assessment finds, they develop a comprehensive management plan for the patients, and this can include prescription of an appropriate gait aid, prescription of adaptive equipment, various environmental recommendations, minor wound management, mobility training with the aims of reducing falls risk, improving confidence and functional mobility, motivational interviewing and health coaching, an exercise program, and referral to relevant services. They also liaise with the patient's GP, family and carers, and then the patients are followed up at 1 month and also 6 months. That's the idea. So the inclusion criteria, like I said, elderly, over 65, falling at home, falling from standing height, not requiring transport, consenting to the service, and falling within the hours of operation. and that's just the catchment area, which is Alfred services quite a large area of Melbourne. So exclusions are, obviously the opposite of inclusion. Residential aged care facilities, falls in public places, also patients who are intoxicated or demonstrating behaviours of concern, and also if the location is noted in our dispatch centre as a location of interest, then we're unlikely to refer the STRIDE clinician because they're a sole responder. And if there's a need for lift assist, the STRIDE clinician can't do that, but we can dispatch non-emerge to do that with the clinician if possible. So our key milestones were we got the funding at the start of this year and we were in a sort of discovery design stage. We employed clinicians through the Alfred and they've gone through a period of orientation, and then they sort of did like a soft start in May with the sort of true pilot data collection starting in July, with the trial proposed to be a 6-month trial with a 6-month follow-up for all patients. So we're anticipating to have the evaluation complete July next year. So from an evaluation perspective, we'll be looking at collecting data from patients, so a 1-month and 6-month post-referral, looking at fear of falling, quality of life, adherence to the plan, their utilisation of health services, subsequent falls. We'll also be collecting data from our electronic our data warehouse where we can look at, we can verify if they've had subsequent use of ambulance or ED, and we can compare them to other fallers. We'll also be measuring satisfaction with the service and doing some surveys or focus groups with paramedics, and also looking at the clinician skill set based on the data collected through the patients. So some of the measures in terms of testing the feasibility are just the number of potentially eligible patients. We already looked at that with our data, but actually seeing the patients firsthand gives a much better feel for that. The number percentage of referrals, the number of percent of patients who actually consent to the service, how fast the STRIDE team get there. At the moment, they're aiming for a 2-hour window, but often the patient asks that they don't come back till tomorrow when their daughter's there, or they come the next week or so. So we're sort of collecting some data around why they're not necessarily meeting that 2-hour KPI. Repeat falls, repeat triple O calls, repeat ED attendances. And we can look at predictors of referral and predictors of repeat falls. And we'll be comparing to our data to data outside of the Alfred catchment area in the metropolitan area, the AV data. We can also look at retrospective data in the Alfred catchment area. We can compare patients seen by STRIDE and those not seen, and we can also compare changes in the actual patients who have the intervention to see if their fear of falling and things like that decreases. So some preliminary results, because it is early days, is that we looked at from June and July, looking at our data, we thought we had about 170 potentially eligible cases, 170 falls in the aged over 65 in the Alfred catchment area, and screening through the patient care records, it looks like about 50 of those a month look like they'd be eligible for referral. But we have had fairly low referral numbers to date. So June was particularly low, where we only had 8 referrals. So there's been a lot of work around educating paramedics, getting the message out there, bulletins. The STRIDE clinicians have been visiting the teams in the catchment area, out in the newsletter. And the same for educating the staff in the referral service that this is an option as an alternative service provider, so you don't even need to send an ambulance, you could send the STRIDE team. And so in order to not have the clinicians sitting around sort of doing nothing, what the Alfred started doing and what we started doing at AV. So the Alfred started screening the ED attendances to see if there were elderly falls that will look like they would potentially benefit from this service. So you can see in July we had 13 patients referred by screening ED records and then calling up the patients and seeing if they would consent to the service. And we also had a senior paramedic review ambulance case sheets and then call the patients and see if they would consent to the STRIDE clinicians visiting them. So we've been doing all sorts of things to try and get it moving and get more of an uptake. But this is all about testing feasibility, and one of the measures is what is the uptake. So far we've had 73% of the patients that have been contacted consent to the service, and we've had no adverse events such as the clinician having to call 000 or take the patient to the ED. Just some high-level sort of characteristics of the consenting patients. So the mean age is 81, 48% are female, 33% living alone, and then higher numbers living with a spouse or with a family member, or with the family. But strikingly, 89% report at least one fall in the previous year, and 22% report greater than 3 falls. And 30% of them report a severe injury in the previous year. So, we do feel like for the ones that we have managed to get referred and consented, this is a really important cohort to get some intervention into. This is just the quality of life. So it's the percentage that are reporting. Blue is no problems, red is some problems, and yellow is severe problems. So apart from the last bar, which is anxiety and depression, the majority are reporting some problems in all the other domains, such as mobility, personal care, usual activities, and pain. But the majority are reporting no problem with anxiety and depression. So. Relatively, and the mean, so with the EQ5D you can get them to do a verbal like analogue scale. So you say from 0 to 100, how do you rank your quality of life today, and the mean score that the patients are giving is 70. So relatively good quality of life. They also do the fear of falling, so the short FES as it's called, and it asks patients about how concerned they are about falling given 7 different scenarios. So getting dressed or undressed, taking a bath or shower, getting in and out of a chair, going up or down stairs, reaching for something above your head, walking up or down a slope, and going out to a social event. And scores of 10 or more generally indicate a high fear of falling. And you can see from this graph, 52% scored greater than 10. So not surprisingly, given the percentage, 89% had a fall in the previous year. So they also have significant fear of falling. So just one case example, so there was a 90-year-old female living at home semi-independently with some assistant to activities of daily living. She had an unwitnessed fall as she was going to answer the door for her carer who comes and assists with some things. The patient stating that she tripped on the walker. The daughter had to come around and let the paramedics in, and the paramedics, apart from the lift assist, just diagnosed a minor abrasion and graze to the elbow, no head strike. So the patient consented to STRIDE and was seen on the same day by the STRIDE clinician. Key issues identified: reduced high-level balance, poor visual acuity in the right eye, ongoing right shoulder pain and dysfunction, and a large rug in the living area posing a trip hazard. So the interventions that they put in place were referred to a falls and balance program, checked that she was actually had glasses, and she stated that she was awaiting new ones to come, provided with a home exercise program and management plan, provided advice on securing the rug, and they did a weekly, they followed up in a week and then scheduled a 1-month review. So in summary, there has been a slow uptake, but we've got numerous initiatives in place to increase awareness. We've had really positive feedback from the patients that have participated so far, from the STRIDE clinicians and from the AV teams that that are referring patients. We haven't had any adverse events, but it's a small sample so far. But one of the aims of the pilot is to ascertain demand and acceptance. So, this is what we're doing with the feasibility study. And obviously we'll do an evaluation which will inform whether, we should be investing in some sort of ongoing service. So thank you very much.